thank you for asking me to talk. I am a radiologist from Imperial. My name is Katherine Van Ree. I'm also Deputy Trust Cancer Lead at Imperial and have been working with our team to set up our non-site imaging specific pathway. So just going to give you a bit of a talk today on the imaging modalities and what they involve, and apologies if it's a little bit like teaching to suck eggs, but just wanted to go over the sort of basics because I think sometimes they're assumed and not necessarily known. Then just to talk about what to use and when, and then a little bit in a bit more detail about CT colonography and fit testing, how and who. And then if we've got time, hopefully at the end, maybe a bit of Q&A around any of the scenarios you've come across that you'd like to ask questions about. So that's broadly the outline. I think we've got about half an hour, so I think we've got plenty of time. So just to remind you, obviously the imaging modalities we have on offer are CT, PET CT, MRI and ultrasound. And I just put these images in because actually the scanners all look very similar from the patient's point of view. And I think that's quite an important thing to highlight, is that so that they know and what they're going to see and expect. And actually, if you haven't been down to the imaging department recently, the modern scanners all look very similar, and it's quite useful to be able to explain to the patient what they look like. So the top is a CT, the middle is a PET CT, and the bottom is an MRI scanner. And the difference to the patient is obviously that around the depth of the circle, if you like. So the bit that they go through, the CT being the least deep, the PET CT in the middle is reasonably deep, and then MRI slightly longer. But even then, our modern MRI scanners aren't that long, and for many MRI scanners, the patient's whole self does not have to be within the tunnel, so they're a bit less claustrophobic than they used to be. And our radiographers in any department are very good at getting nervous patients into the scanners. Where that fails, we do have the option of an open MRI machine, and a sort of illustrated example of what that looks like is on the top right. Really the only difference is at the sides. The patient's face, if they're having their head imaged, for example, would still need to be within the scanner, but you can see it's just a bit more open at the sides. And the other main component of something you may or may not have seen before in terms of the MRI scanner is the use of coils. And that can make the patient feel more or less comfortable depending on which bit of the body they are having imaged. So the coil essentially acts as like the antenna for the MRI scanner and detects the radio frequency signals coming back out of the body. So it has to be over the part of interest that you're scanning. So, for example, the top left is a head scan, and then there's a knee, and then there's a body, and then there's a shoulder. So you can see how actually for various different types of MRIs may be much better tolerated than others, because for the knee, for example, only the leg and lower torso of the patient actually enters the tunnel, and the coil is over the knee, whereas for the head or the shoulder, it tends to be a bit more claustrophobic. So I think it's just a sort of important thing to note what we then put onto the patient when they then come for an MRI. So just to talk a little bit about CT in terms of modalities, so we'll start with CT and then move on to the others. Tends to be the workhorse of our department. It's very quick to do on the whole, scan time only being a couple of minutes and very little preparation. As I'm sure you're all aware, it uses IV contrast as its, iodinated contrast as its intravenous agent. And I just thought it'd be helpful just to touch on the contraindications, the absolute and relative ones, and some of the sort of myths that exist around it as well, because obviously now you're requesting these things. I think it's important that you fully understand what you're asking for. So obviously an absolute contraindication is any documented previous severe reaction to iodinated contrast media. And what we mean by a severe reaction is anaphylaxis, a clear history of angioedema and bronchospasm. They're not allergic reactions. These aren't immune mediated on the whole. They're hypersensitivity adverse reactions. So the sort of contrast allergy is a slightly false term. And then we would say relatively mild, relative contraindication would be a milder previous reaction. a history of renal impairment or failure, but obviously we know that that's not a complete, and there's many times that we give patients with renal impairment iodinated contrast. If they've had previous adverse reactions, history of myasthenia, and if they have risk factors for adverse reactions to contrast media, they're also sort of relative contraindications, but it's more something to discuss than something to necessarily obviously prevent them having the CT with contrast in the first place. Overall, the risk is really very small, 0.04% to 0.0004% incidence in all scans. So what are those risk factors that increase the patient's risk for a reaction? So if they have a history of hypothyroidism, that's about a 3.5% increased risk. If they have a family history, or any very significant allergic disease, so mild asthma isn't one, but if they have, unstable, brittle asthma, things like that, they are more at risk of developing a severe contrast reaction. If they're an allergic patient generally, so if they have multiple allergies to other things, they're more likely to have a hypersensitivity reaction. And slightly bizarrely, anxiety. So studies have shown that patients with very high levels of anxiety have an elevated risk of what we call non-vagal adverse reactions. But the thing probably to pull out on this slide is that you hear a lot talked about shellfish allergy and whether patients with skin irritation secondary to topical iodine, when they've had it for surgery preparation or something like that, they do not have an increased risk of contrast media reaction. So that's just an important one because it's one that's often been talked about in the past. So in terms of renal impairment, what we ask for is most stable outpatients. So most patients that really you'll be seeing in the non-site specific setting, they need a minimum of their GFR done within 3 months. It's not really an issue because those patients obviously tend to be referred with a full complement of the filter function test, which will include U's and E's. But just as a general principle, that's what we ask for in outpatient imaging. If they're acutely ill or they're known to have renal impairment, we ask for it within a much shorter time frame, usually about 7 days. But as I say, if it's stable renal impairment, then as well we take a relatively relaxed view on that. But if it's an acute renal impairment or an acute illness, then it does need to be near to this time of the CT. And generally, adults with a GFR of less than 40 mils per minute are at increased risk of contrast-induced acute kidney injury. And the key values we sort of use in the imaging department are less than 30, 30 to 45, and over 45. So less than 30 is usually a no, unless they're on dialysis, very stable, and they've had a specific discussion with their renal consultant. 30 to 45 is discuss options in terms of what we're doing the scan for, how necessary is it, and then a repeat renal function 3 days afterwards. And greater than 45, obviously no worries. So in the setting of the non-site specific pathway, CT is your main thing, really. So for almost all of the indications on the referral form, such as unexplained weight loss, new prolonged fatigue, non-specific abdominal symptoms, including bloating, pain and nausea, or unexplained progressive pain, CT chest, abdomen, pelvis with IV contrast is what you will do. This is done in a portal venous phase. What this means is that after the contrast is injected, the scan is performed approximately 65 to 70 seconds, and that allows time for all of the solid organs and the non-solid organs to enhance, and basically that allows visibility for almost all types of tumours that we will be, or you will be looking for on the non-site specific pathway. So that is the main workhorse, and I'm sure you're well aware of that. So there are certain situations where we may want to tailor the protocol or request something slightly different. Pancreatic cancer being one of these. So most pancreatic tumours will be picked up by a standard portal venous phase CT, and this is an example of one of those when they're big and obvious and causing secondary things. So here you can see a large mass with the asterisks centred on the head of the pancreas. The pancreatic tail upstream from that has duct dilatation within it, which is the sort of darker grey rounded bit within the structure to the right. And then there's also vascular involvement here outlined by the arrow, where there's a filling defect within the SMA. So most pancreatic tumours, as I say, will be detected on the portal venous phase, but if you strongly suspect one and you want to make sure you're covering all bases, then a pancreatic protocol can be requested, and it can be done in combination with a chest, so you don't have to do one and then the other. But basically that uses an unenhanced arterial and portal venous phase scan, so it is a high dose, so that's something to just be mindful of. We do it because some smaller pancreatic tumours are only really very well seen on the arterial component of that CT. So the ones we're really talking about here are neuroendocrine tumours, and they tend to be small and then very white, so very avidly enhancing on the arterial phase. So this is just a little example of that. So the arrow is pointing to very round, bright white lesion, shows it's avidly enhancing, and the sequence or the scan timing on the left-hand side is the arterial phase, and then on the right-hand side is the portal venous phase, and you can see it becomes much less conspicuous on the portal venous phase, and actually some of them become almost completely the same shade of grey as the adjacent pancreatic parenchyma. So you have to really sort of be scrutinising for just bulges in the outer aspect of the pancreas or some other very subtle sign, whereas as you can see it really catches the eye on the arterial phase. Hematuria is another indication which you may need to be aware of. I mean, most of these will obviously go directly to the urology 2-week wait pathway, but sometimes they won't, and they will come to you. And in those situations, we do something called a CT urogram. So the principle behind this is that it's a split bolus of contrast. So contrast is given once, and then contrast is given again, and then the timing of the scan is done so that we have both enhancement of the renal parenchyma, but also, as you can see here, what we call an excretory or urographic phase, which is when the kidneys are excreting the contrast. It makes the collecting systems white and allows us to visualize things like filling defects within the collecting systems, which is what TCCs look like. So on the left-hand side, you've got an example here of the portal venous phase of the kidney, and you can see you can still make out the soft tissue mass within the renal pelvis, but as you can see on this other one, this is the excretory phase where the collecting system is filled with contrast, and then you can see the filling defect of the tumour much more clearly. So if you have a patient with mixed things, one of which is hematuria, you may want to also think about including this on your request form. So this was just to show you what we use in the 2-week wait pathways. As I sort of referred to before, these will typically go directly to those 2-week wait pathways, but if a component of them are seen within your clinics, I think it's important to have oversight of what we use. So lung is a standard CT, brain, I think that would be very unlikely to come to you, but CT first, and then MRI, depending on what that looks like. As you know, breast is a triple assessment, which is mammography, ultrasound, and clinical assessment. I think breast will almost never come to the NS, non-site-specific pathway. Renal and bladder, so hematuria is CT urogram. Gynae cancers is ultrasound in the first instance, and then MRI. CT is then only used for staging purposes, really, in gynae malignancies. Anal cancer is detected clinically and then staged with MRI. HPB tumours is ultrasound as the first line often, not for pancreas. Pancreas was obviously first line as a CT, and then CT and MRI used in different scenarios, and I'm happy to sort of ask questions about when you may use those if required. OG, so esophagogastric tumours, are endoscopy and then CT for staging. Prostate, as you know, is the rapid MRI pathway, and colorectal is a normal CT, depending on what we've done already, or a CT colonography. And I think probably just useful to spend a bit longer talking about CTC, because that is something I think you will request, and it's important to know when we do these, why we do these, how we do these, and who we should really be doing them in. So it's best, I think, for us to regard CTC as a luminal assessment of the colon, which is comparable to colonoscopy for the detection of significant polyps and suspected cancers. It really doesn't have any other use in terms of from the colon point of view. So it's not for colitis, it's not for inflammatory bowel disease, it's not for diverticular disease, it's literally for the detection of polyps and cancers. It requires a patient preparation in the same way that colonoscopy does, over a 3-day period. So patients are given an oral laxative, which is generally much better tolerated than the colonoscopy, the prep required for colonoscopy. So it's much less purgative, and so even the more frail patients can usually tolerate this. They then need a low residue diet, and we also give them an oral fecal tagging agent. And what that is usually gastrografin, which also has a bit of an osmotic laxative effect. So the combination of the tagging agent and the oral laxative are the sort of bowel preparation in terms of removing any residual stool from the colon. But then what is left is then tagged white by this fecal tagging agent. And I'll show you some reasons about why that's important in a minute, but it is very important, and without it, the sensitivity of the study is really reduced. So it's really important that when you see patients in clinic, if you are requesting these, that you go through with them exactly what's going to be required, and that they sort of convey the importance of adherence to the preparation. CTC is typically done, well, originally was typically done without intravenous contrast. You do not need intravenous contrast to look for polyps or cancers. It's given, patients are given intravenous contrast when doing a CTC if we're also looking at other stuff. So if we're not that sure what it is, and we also want to look at the pancreas, the liver, the kidneys, etc., then we will give it. But for many indications, such as when we do it for the bowel cancer screening program, we do not give it, because it's literally purely to look for the polyps and cancers. Patients will come in, they will have their consent done, they will have a tube put into their bottom, and then their colon insufflated with approximately 2 to 3 litres of carbon dioxide. So it's obviously quite uncomfortable for them when they're that distended, but it's generally quite well tolerated. They then have typically 2 scans, but sometimes 3 or maybe 4 scans in different positions. The classic 2 are a supine and a prone, and this is to move any residue that's left within the colon so that you can analyse the wall behind it. So when obviously if there's a lot of residue in one part of the colon, it's very difficult to see the wall clearly. So then when you move them, the idea is obviously it all moves into the opposite side, and you can see that bit of the wall that you couldn't see before. And that's why we might do an additional one, or if the insufflation is poor, we may do additional scans. So it's quite a lot of scanning time for the patient compared to a standard CT. And the slot time would be 30 to 40 minutes as opposed to a sort of 10-minute, 15-minute slot time for a normal CT. So it is a significant resource. This is a very busy slide, but it was just to, I suppose, give you a bit of an overview of what's being proposed in terms of how CTC will fit into the lower GI cancer diagnostic pathway, i.e. when might you request a CTC versus when might you request a colonoscopy. And it's really those 2 boxes in the middle. And there's no hard and fast rule. It is obviously based around the holistic assessment of the patient and their optimal test suitability. But there are things that would favour a CTC and those things that would favour a colonoscopy or a flexible sigmoidoscopy. And they're listed in this box. So favouring CTC would be patients that are FIT positive but with a slightly lower FIT level, so less likely to have a significant polyp or cancer, because one of the obviously main principles is duplication of tests. So you don't really want to be doing both. So if a patient has a FIT test of 250, for example, and they're fit enough to have a colonoscopy, you're much better off referring them for a colonoscopy than a CTC. as we sort of discussed, if there are other abdominal symptoms also requiring evaluation, then a CTC is a better choice because you can do that at the same time. And then comorbidities, obviously CTC is preferable in those circumstances, and a bit of patient choice. I mean, we obviously have to guide them as to what we think is the most suitable test, but they do obviously have a right to also then choose what they would prefer to some degree. So I won't go through everything, but obviously the slides can be shared and you can have a look at this and ask any questions about this if you have any further questions. So this is the kind of image that's produced. So at the bottom is the standard CT image of the insufflated colon. So the air within the colon is all black. And you can see some of the small bowel has also been insufflated as well, which you often see. So these small bowel loops down here, when the ileocecal valve is a bit incompetent, you just distend everything. And sometimes you get distension all the way up the esophagus and patients burp. Because their ileocecal valve is so incompetent, you've just got one obviously open communication all the way to the mouth. And then once we acquire these bottom images, we then use a software package to reconstruct, and you get an endoluminal view, so an inside view of the colon, which is comparable to the colonoscopy here. So here you can see a polyp along a fold. That's how it looks with a camera, and the two of them are really very similar when done well. And this was really just to highlight why we need to be mentioning to patients that they really must take the preparation that we give them. So this is the fecal tagging agent having turned this residue within the colon white. This is a little blob of poo within it, basically, and these can mimic polyps. And without the tagging, we wouldn't know. This would just look very bland and grey. And we wouldn't be able to tell whether that was a polyp or some fecal residue. So that's one reason we can overcall or undercall abnormalities without it. And then the next picture down the bottom is, I don't know if you can you see that? Just my little graphic over the top of it. Okay, is that better? So this one down the bottom, without this fecal tagging agent, all of this stuff here at the back would be grey, and this is actually a polyp, and we would not be able to see that. So it allows us to sort of see through the fecal residue as well, if you like. So you can imagine if this was grey and this was grey, it just becomes completely invisible. So MRI, so we'll move off CT and just focus on this for a bit. So this has superior tissue contrast and gives greater anatomical detail to structures, but it is a lot longer. It takes on average 20 to 30 minutes, and some scans can take up to 45 minutes to an hour, depending on how many sequences we do. As we've sort of talked about before, patients can be prone to claustrophobia within the scanner. The modern machines being less so. The radiographers, as we said, are very good at getting them in, and the open magnet is another option, but it requires individual funding requests to the CCG on each patient, so it's difficult. And they also have had to, I think there are some criteria where they've had to have failed going into a conventional scanner at least once, maybe even twice before, so it is a sort of last resort, and the image quality is also not as good. So we really do try to get patients into the scanners if we can. Pacemakers, so they're not complete contraindications anymore. They've been approved in circumstances since 2017, but they do require a lot more time and a lot more process around it. So the consent process is longer. The pacemaker has to be turned off, checked before and after, and so it just takes a lot more coordination and uses up a lot of time on the scanner and in the hospitals. So it is. We do ask that it is a sort of reserved for the times when it really, really is needed, but we do them. MRI uses a gadolinium-based contrast agent. It's very safe. It's even less incidence of severe reaction than the iodinated contrast agents. There are also some relative contraindications, pregnancy being one of the main ones, renal impairment being another. We use the same cutoff at 30 mils. And if they've had a previous severe reaction to an intravenous contrast agent. But it is not that someone with a severe reaction to an iodinated agent will also have a severe reaction to a gadolinium-based agent because they are different. So it's just a relative contraindication which we would need to know about, but we would then talk to the patient and find out exactly the history of it all before we made a decision on whether or not we could or couldn't use it. Many MRIs are done without intravenous contrast, and it's not usually an issue. There's a slight increased risk with a history of asthma or severe allergy, as before for the iodinated agents, and the renal impairment timeframes are as before as well. So 3 months, ideally a week, depending on the circumstances, but slightly longer if it's stable. So when do we use it? Well, it's really limited, I think, in use for the non-site specific setting. I was sort of struggling to think of a primary indication where you might, and probably young patients, so less than 40, you might consider as an alternative where they've got clear abdominal symptoms requiring cross-sectional imaging. They really don't want, and you actually think the risk benefit is such that they shouldn't have ionizing radiation. It could be used then, but CT is better generally for all the reasons listed, but it is an alternative. So we could do an abdomen pelvis, for example, for someone with vague-ish abdominal symptoms. When you might be requesting it typically would be for further characterization of an abnormality on a CT or an ultrasound, or if the MDT you're referring to has asked you to sort of do it to expedite the staging things as they're referred. So sort of bundling of tests prior to the MDT that we know that the MDT would then just need to request. Typically, a recommendation in these circumstances will be made in the report, so you'll know what to do. But the examples where we might do it would be an indeterminate liver lesion, a cystic abnormality in the pancreas, a large cyst on an ultrasound for gynae, for example, for further characterization, indeterminate renal lesions, adrenal lesions. I put prostate and MSK in here, but really those should be going separately. If you've got something that needs a prostate MRI, that should be being seen on the rapid pathway. And MSK tumours at Imperial we refer to as specialist sarcoma unit, and I think that's probably similar across the sector. Small bowel, MRI, anal cancer, as I've said, brain and head and neck and breast. But again, these are all likely to be things that there's either going to be a specific recommendation in the report, or these are more likely to be seen on the tumour-specific pathways. So PET-CT, again, rarer its use as a first line, but you may need to be thinking about circumstances when you might use this. As I'm sure you are aware, we use FDG, which is the radioactive tracer used to detect metabolic activities. There are more modern tracers for specialised studies, so around prostate cancer and things which you may have heard of, but the workhorse of PET-CT is FDG. It's given IV, and it detects the distribution of the radioactive material, and then we combine it with a non-contrast CT. So you get lots of different images, some of an unenhanced CT and some purely of the distribution of the radioactive material, and then they're fused and we get an image with one superimposed on the other. They are expensive and they take a long time. So that's why they're obviously not the primary thing that we do for investigations. One of the things that's important for the patients to be aware of are they typically emit very low levels of radioactivity for approximately 6 hours afterwards. So there are some things that they'll get advice to avoid doing in that time, but it's very low levels and almost no, such very little risk to people. So many of the applications of PET-CT aren't that relevant. So it's usually as a part of staging after cancer or suspected relapse when the initial imaging has been equivocal, or we use it for response assessments in patients that are on treatment. But where you might use it and would be a perfectly valid indication would be in the detection for paraneoplastic conditions where the primary imaging has been equivocal. So we would still recommend doing CT to begin with rather than going straight for a PET-CT in these circumstances. And the yield here is variable. Our sort of nuclear med team say it tends to be around 10%, less than 10%, that you will actually detect a primary tumour in someone with what is suspected to be a paraneoplastic condition when the first CT has also been negative. But the literature suggests it's between 10 and 40, but our experience isn't that. I don't know what the other experiences of the other departments across the sector in, but I suspect it's lower. A cancer for unknown primary, we obviously use it when we know we've got peritoneal disease, for example. All the other investigations have been negative. PET CT would then be used as a sort of last ditch effort to try and detect a primary tumour. Typically, they will have been referred on from the non-site specific pathway by this time, but if not, that's a good indication. Pyrexia of unknown origin and suspected vasculitic disease. It's again pretty sensitive for detection of vasculitic disease, but yield is low. And then lastly, ultrasound. Obviously, it's probably one of the most common things you've been used to requesting in the primary care setting, but in the non-site specific pathway, it's used as a first-line detection for cancers or evaluation of organs where cancer is suspected is less. So really gynae, which probably won't come straight to the non-site specific pathway anyway, but that it would be our first line investigation for almost any gynae presentation. Also, if we know there's an ovarian cyst and it's small, so 7 centimetres or less, ultrasound typically sees it very well. MRI will be used as an adjunct, or if it's larger. The reason for that is once it gets larger, actually your ability to see the entire wall of the cyst is a bit more limited on ultrasound, so we know that there might be bits of it that we miss. So we always recommend MRI in cysts that are larger than 7 centimetres. But liver and gallbladder, ultrasound is actually one of the best tests for the gallbladder, far better than CT and often better than MRI, depending on the patient parameters. And liver is often very useful, both as a primary detection, but we also now use contrast-enhanced ultrasound for liver lesion characterization. So this image is an example of what that looks like. So on the top left is a lesion within the liver, and then the contrast agent is administered, which is microbubbles, which are then injected in a saline into the patient, and then the patient is scanned real time with ultrasound. And it allows you to see the enhancement pattern of that lesion in the same way that you would see it on a scanner, but in obviously a very dynamic real-time way, because you're literally watching as the lesion opacifies or does not opacify. And one of the most common uses for this is whether a lesion is a hemangioma or a metastasis, and it's very good at determining whether that's the case. And then I just put breast in because obviously it's used as a first-line assessment for breast, but it's not particularly relevant for you guys. So that's probably actually all I was going to say. And then depending on how long we've got, which might be 5 or 10 minutes, take any questions, and or if you've got any scenarios you wanted to ask about, I would answer those. Anything you've come across that's been tricky or you've been unsure of or you want clarification on, then I'm happy to take any questions. I can't actually hear anybody.
We saw a patient, Katherine, well, Alex, I think, saw the patient who had a sort of who has a sausage-shaped lesion that was on ultrasound, had some blood flow, and it was in the abdominal wall. And I wondered whether it would be more appropriate. We ordered a CT on it, and I'm just thinking, based on your presentation, whether an MRI would be more appropriate.
Probably, yes. So MRI for soft tissue, so fat, muscle, things within the abdominal wall, MRI would be better on the whole, yeah.
Yeah, okay, so maybe I'm not sure it's been scheduled yet, so that might be the thing to do, Alex. Thank you.
Yeah, the radiographers are generally very good, so they vet all of our scans. Anything they're not sure about, they'll ask us about. So as long as you put, all I would really encourage you to do, obviously, is having an awareness of everything, but just put the clear clinical details in the request form. And even if you're not sure, you could even write in that, not sure if this is this or this is this, and then go for the one you think it is, and then the radiographer will vet it. And if there's a query and they're not sure, they'll come and ask us. So don't be worried to put as much information as you want in the clinical details, and then we can take it from there, basically.
Thank you. Thank you.
In order, Owen Carter.
Hi there, yes, I'm Owen from St George's. We've been doing our clinic for some time, and two very quick questions. I've never really considered doing an MR abdo-pelvis for younger patients, and normally, sometimes our MP might do an ultrasound abdomen, which is kind of useless, gives a bit of information, but not much. And then it would go for how to do a CT. And I was just wondering, obviously, if you've got a strong clinical suspicion, then probably it does go to CT. But I suppose it just be useful to get some clarification when MR might be kind of a useful kind of midway thought, really. And the other question I had was in terms of for our CTC protocol for George's, we tend to use that for patients that are more fit negative, but there's still an underlying concern of a colorectal cancer where they're more constipating rather than diarrhea. And I just wondered if you agree with that approach.
So the first one around MRI, I think if you've got a very strong suspicion that your patient has cancer, then a radiation dose from a CT, even if they're young, is not going to be particularly significant. If the patient voices concerns about that, then it's a reasonable alternative. If it's a bit vague, but you do think they really need some form of cross-sectional imaging, then an MRI would be a reasonable option in a young woman, particularly, but in any young patient. And by young, I do mean young, like less than 40, in their 30s, 20s kind of thing. So I think that is a suitable alternative. You can't use it for the chest because you don't see the detail in the lungs. So they would, if you still needed to include the chest to look for lung pathology, then they're going to have a CT of some description. The risk from CT is very low. So we are talking, very, very small levels akin to, a few plane trips across the Atlantic, no more. So on an individual basis, from a one-off scan, the radiation risk is incredibly low. It's more the patients where, this isn't necessarily relevant, but Crohn's patients that have had multiple CTs on admissions for acute bellies, that are young, that are the people we worry about. So strong suspicion of cancer in a young patient, we do all the time, but it's just if they then voice, concerns, it's a suitable thing to consider. But I wouldn't want you to take away that do it as an alternative in every young patient, no, because you'll drown your imaging department with MRI requests. So a CT would still be better in most indications, but it is an alternative if they're concerned about it. What was the other question around CTC?
Yes, so we tend to do CTCs in patients that are more constipating with weight loss, fit negative, rather than going for colonoscopies.
So there's two things. So the most recent guidelines around fit are that patients can be safety netted if they don't have red flag symptoms for a lower GI cancer. So they can be safety netted for 6 weeks and a review at 6 weeks if their fit is negative. So that's sort of one component. But obviously, if the symptoms are still concerning enough that you suspect them from having a colorectal cancer, obviously we would then do it. And the only reason I would say from diarrhea to constipation would be if they have diarrhea, if you're suspecting inflammatory bowel disease, that would need to be a colonoscopy. But otherwise, change in bowel habit is a change in bowel habit. Doesn't matter if it's constipating or more towards slightly looser stools. But if it was proper diarrhea, where the patient's going 10, 15, 20 times a day and you expect colitis, then colonoscopy would be more appropriate.
Thank
you. Who's next? Sorry, I can't see the numbers anymore.
We've got Vaishnavi.
Oh, thanks.
Hi, thank you very much for the talk. I'm Vaishnavi, I'm the GP at Norfolk Park Hospital. Just coming back to PET CTs. So we've been caught out in our service a couple of times by requesting the wrong type of PET CT. And so there's the FDG and then there's the dotatate PET. And I think it'd be useful to just get clarity on whether it's worthwhile just doing an FDG PET on everyone, or is it worth to kind of be selective right at the beginning for primary or for cancer of unknown primary.
So first of all, they should have CT first before they have anything, and then if the CT is equivocal, then you can, for cancer of an unknown primary, it would be FDG PET almost invariably. The dotatate scans are used for neuroendocrine tumours, so those that secrete a particular agent. So that's really the only indication that you'll come across where it's used, and it's usually used for, well, first of all, when it's suspected. So say, like that CT I showed you at the beginning where you see a small arterially enhancing lesion in the tail of the pancreas, then and you would strongly suspect a neuroendocrine tumour in that case, and then it would be a dotatate, or it used to be called gallium, just a slightly different agent that's used. That would be that type of PET CT. But again, if you put that in the clinical details, your PET CT department should vet that and flag that and say, oh, you've put query neuroendocrine tumour, but you've requested an FDG PET. They should sense check that for you. But otherwise, FDG PET is is what you're asking for.
Thank you.
Baldi.
Hi, Katherine. That was brilliant. Thank you. I've got a quick question about CT and CTCs. So very occasionally we'll see patients and the FIT hasn't come through. Then the FIT comes through. We've already organised the CT scan, or they've already had the CT scan, but then the FIT is between 6 and 10. In that situation, I guess it depends on symptoms as well, but we often see the vague symptoms, don't we? So it's weight loss. In that situation, would you then go on to request a CTC, given that the FIT is sitting between 6 and 10?
So I think the value is less than 10 is the safety net. And if you've already had a CT, when you say you've already had a CT, do you mean a standard chest, abdomen, and pelvis?
Yeah.
So I think you'd have to be very much guided by the abdominal symptoms that they had. If they were just weight loss and then you got a fit back of 8, I don't think that would prompt anybody to then purely on that do a CTC or a colonoscopy.
Yeah.
If they then had no GI symptoms. But actually then if you went back and you talked to them, actually they had a bit of change in bowel habit, they had a bit of something else that was a bit more concerning, then I think it's reasonable. And you really can't exclude a cancer on an unprepared CT. So it wouldn't be that you'd sort of done it a bit, you just haven't really done it very well, as in not you, but the test hasn't done it very well. So I think it would just be a revisit to their lower GI symptoms and then a view from that. But if it was just weight loss, no.
Yeah, brilliant. Thank you so much.
No worries. I've probably talked for a long time now, so that might that might be enough. But I can't see any more questions.
Yep, it looks like we're questioned out. But thank you very much, Katherine, for that very thought-provoking and informative presentation today. And thank you also for those that asked the questions as well. So, like I said, this is being recorded, and Katherine, thank you very much for volunteering your slides. If you wouldn't mind, we would definitely kind of want to circulate those as well. So, if there are any, whilst you're kind of digesting all of this information, if there are any questions, Katherine, would you object to people kind of emailing you individually?
No, that's totally fine. I was going to say the same thing. So if anyone wants to drop me an email with something that they've not thought about or something they want to check, I'm happy to answer them. Obviously not on a daily basis about every patient, but generally in broadly topics is all fine.
Brilliant. Thanks very much. Well, without further ado, I'll let you all go. But thank you again, everybody. I really appreciate you coming today, and thank you again, Katherine. Have a lovely afternoon.
I'll